A great live stream we have prepared. I've got my good assistant here and manager, Memo Hea, who's going to be helping us out with our live stream. And so we've gotten a lot of questions from viewers and from patients who have asked us to go through the process. So, and Memo and I were talking about this the other day. You know, the process consists of basically two things. And I'll use the analogy of building a house. When you're building a house, you've got to, first of all, you've got to figure out find the lot, right? And then you start to prepare the lot. You've got to level it off. You've got to do soil, foundational checks. I know that by my brother's house in Utah, they had built these beautiful multi-million-dollar homes, and they did not go through the city to do some soil testing. And because of all the snow that they had in that area and then runoff, and the water had pushed 3 or 4 homes off of the hill, and you could see the debris path with drywall and bricks and cement, and nothing was going to stop these houses from sliding off the hill. The power behind the soil and the wet soil just wiped these houses right off the hill. So, and these were brand new homes. They were literally brand new. So they, without proper testing of the soil, without proper planning, with cutting corners, basically, because I was told that they didn't go through the city, they didn't get proper inspections on the soil. So they lost these multi-million-dollar houses as a result of improper planning. So why do I bring that up? Because it's very similar. If we don't properly plan out the foundation of the final set of teeth, and the foundation is the surgical phase. It's the preparation of the bone. It's the preparation of the sites or the osteotomies for the implants. And all of that has to be done and executed perfectly. If not, the house will slide off the hill, so to speak. The investment that the patient makes, the teeth that are fabricated on top of a foundation that's not sound, eventually will fail. It will definitely, because it's too much force. It's, like I say in all my videos, there's just way too much biomechanical forces going on. And if it's not planned properly with the proper number of implants, and then the foundation isn't properly executed and decided upon, then the problem is the patient loses because they have invested. And then, like in the situation with these homes, these people were basically out. The insurance would only pay a certain amount. They weren't going to pay all of the value, and not to mention the time that they had to spend in hotels, and then they got to find a new house. I mean, it was quite a mess. So, I liken that to the situation where you've got, and in the beginning I started to talk about, so there's 2 different aspects of the process. When the viewers ask, take us through the process. Today, we're going to take you through the process of the surgical aspect, which is kind of laying the foundation, building a solid foundation, because we want, this has to last you the rest of your life. Once you get it done, it's got to be something planned out properly with a good solid number of implants, so that in the end, the investment that you make is one that you can count on. So, all right, so we're going to go through, and I'm going to share my screen, but we're going to go through kind of detailed, and some of it is surgical video. So hopefully you can handle that. But the way I look at it is, when I look at basically the body itself, I mean, God has made us and our bodies perfectly. And when we look at some of these surgical videos, if we look at it from that perspective, even the architecture of the bone and the gum tissue and the teeth design, I mean, it's a remarkable thing. And so when I look at, surgical videos, of course, there's going to be some blood, but the blood is basically the healing balm. I mean, when there is blood, there is healing. When there's not blood, healing is very delayed, and a lot of times it doesn't happen. So, and for me, blood is an essential aspect of healing. It's an essential aspect, obviously, of our bodies. And I kind of look at it as a beautiful thing, and how it's designed and how our bodies are designed is remarkable and is a testament to our Creator. So just a little side note, if you're not comfortable with blood, they're just a little bit, not a whole lot. So all right, so I'm going to go ahead and share my screen, and we're going to look at some different cases. And again, bear with me because I'm an absolute kind of idiot when it comes to these sort of things.
Just the folder up there.
All right, so here's a case. Here's a patient who has, and if you'll notice that her front tooth is left, the one next to it is broken off at the gum line. And I think you can see my mouse. I'm not sure. I'm going to try and move around anyways with it. So this tooth is broken off. This tooth is left. She's lost all of her molars. She has a few molars on the upper, but she's lost all the molars on the lower. That's the patient's right side. And then in the back on the left side, on the patient's left side, it's on the right side on the screen, she's lost also her molars. And so these bicuspids and canines, so the lower front, the bottom lower teeth are touching the gum of the upper teeth. And so this is how she has been managing for many years, and also very common. I see this all the time in my practice. But the functionality, there is no functionality. She is literally, what we call, when she tries to eat the food, she's chewing with her gums. So the pain of that has got to be tremendous. So if she's, tries to eat anything of substantial density, whether it's a, hamburger, a steak, or a salad or anything, she'll never be able to masticate or chew it up. It just won't happen. So, she's on a very soft diet, mac and cheese, mashed potatoes, mainly carbs. And that's because she cannot masticate or chew her food. So, this is a very classic, typical case that we see here at Trust Implants. And so I want to go through the foundational development process. When we look at this case, or when I look at this case, I have to start thinking, okay, what is my end goal? What's my plan? How am I going to take kind of a catastrophic situation with the way her teeth are and restore it back to normal, natural function to where she can chew and eat and smile and really get, have this problem go away, because this problem will go away. And once we're done with her case, this will no longer be an issue. She'll be able to eat whatever she wants, and more importantly, give her back the self-confidence and give her back what she's lost. So having lost her molars, so she's lost what we call vertical dimension. The vertical dimension is the distance between your nose and your chin. So and you can imagine as you look at this photo, as the teeth collapse, and as, at one point her teeth were in this position, but as they've collapsed, the distance between her chin and her nose collapses as well. And that always ages a person. It makes them look a good 10, 15, 20 years older, simply because they don't have the facial support anymore of the teeth and the jaw, the bone and the teeth. And so by opening that back up, giving her back the vertical dimension that she has lost, it's going to give her a more youthful look. Aesthetically, it'll look amazing. And also functionally, it'll put her back into the position she was prior to losing her teeth. All right. So anyways, yeah.
Is this a result of just
poor hygiene, or did something happen for this to get to this point?
That's an excellent question. And if you look at the gum tissue, right? If you look at the gum tissue, it's not inflamed. It's not, there's a little bit of inflammation, but this is what we call iatrogenic. And what that means is it's caused by the dentistry that she's had. You'll notice this crown over here. So on the patient's left side, or on the screen on the right side, there's like on the crown, there's kind of a dark spot, which is metal. So these are porcelain fused to metal crowns. And so that dark spot there is the dentist, as he was grinding away, trying to make this bite fit, because he didn't have a plan. And also he probably just did a crown here, did a crown there. And over the years, she spent lots of money on crowns and on, trying to get her mouth fixed. So it's not a question as if she didn't try, because she has crowns on every single tooth. So she spent a lot of time in the dental chair. But this to me is very indicative of the dentist just grinding away without any plan. And then ultimately he's like, oops, I went through, and he's ground all the way through the porcelain down into the metal. And obviously, let's say you had a crown or something done, and the dentist had ground through the porcelain, and now you've got this big piece of metal showing through. I mean, that's just, you wouldn't accept that, right? But because her mouth is in such disarray, she's just had it all done, root canals and crowns and then extractions and lost teeth. And so to me, in reality, this is, no one has taken charge of her case. It's been, I don't know if she's had multiple dentists. I really didn't get into that with her, but going from one office to the other, and just no one's really taking control of her mouth. And so to answer your question, I don't know why she lost her molars. Could have been some periodontal disease, but I really don't see, like, her gum tissue is very clean. I think she tries to maintain hygiene. And so in reality, I think it's more just a cause of just having gone to the dentist and having a crown done here and a filling here and a root canal and then extraction. And then, it's just this domino effect. And that's why we're doing this podcast and this live stream, is because we want to stop that process. It's a broken system. It's one that 99.9% of the patients are in that system. Again, you've got these big corporate offices, the Pacific Dentals, the Aspen Dentals, the Clear Choices, and they are all about the bottom line and the dollar. And so, as I was driving here today, I just heard that Clear Choice is switching their implant system, which we talked about that on our last live view, and they're going with the Straumann BLX implant. And again, why would you switch systems? The only reason they would switch systems is because they've gotten a better deal. That's not because it's a better implant for the patient. It's not because it's not a good implant. It's an implant that has so many issues. And we know that firsthand in our practice. We did attempt to use that system for about 3 months, and I basically just said I can't do it. There's just so many issues with it. But so at the end of the day, if they fall into like an Aspen Dental or a Western Dental type of situation, they're just going to get the bare minimum. They're just going to get, they're not going to get comprehensive work that's going to fix or solve these problems. So it's a combination of dentistry, and then also, again, I don't think it's really hygiene, but it's also, right now, it's traumatic occlusion. The way that her bite is, those teeth just can't last. So anyway, then there's just one case,
Yeah.
So, all right. So let's go through, and we're going to look at laying the foundation for this patient, so that we'll look at the surgical aspects. So again, we're going to get into some video that has some, I'm going to be extracting these teeth, showing why the extraction, everything from the design and the plan of the case to the execution of the surgery. Extracting the teeth are critically important, and how they're removed, maintaining bone structure as you do the extractions, cleaning up any infections. So if you'll notice right up here on the right, just to the right of the central incisor, there's a little bubble right there, so that I know that there's an infection on the root of the one that's fractured underneath here. So, all of these things have to be considered when approaching a case like this, and knowing what and also, of course, you need your radiography, you need your CT scan, x-rays, so you know what you're dealing with before you go in there. All right, so let me go ahead and pull up the video of this case, of the surgical video. So we've kind of gone through, let's see, how do I go back here? All right. Is this it here?
Yeah, that's the one. And then.
Okay, so we're going to pull this video up here. All right, so here we are, patients under general anesthesia. This is a nasal intubation, so we just put the nasal we intubate the patient through the nose, and now we're extracting the teeth. And you'll notice as I'm extracting the teeth, I'm not just kind of just ripping them out. I'm very gently and carefully rotating back and forth and making sure that I am careful about, and I check each tooth. Every time I pull a tooth out, I look at the end of it, I look at the tooth, make sure there's no bone attached, no infection or granulation tissue attached, and also no broken root tips. And then I start to make my incision. So I'm making the incision here so that I can start to visualize. I need to be able to see the entire ridge. I've got to be able to inspect the ridge, inspect each extraction site, so that I know if there's a lot of times when you pull a tooth, there's a dehiscence or bone that's missing. So, and it's not uncommon that that's the case. So when I raising the flap or pulling the tissue away from the gums or from the bone is really important, so that I know exactly the template that I'm dealing with. And so and in her case, I'm actually elevating up to the floor of the nose, and so I can see exactly how much bone I've got to work with. Even though I know this on the CAT scan, I know what I'm dealing with, there's nothing like visually seeing it in the mouth. And so and a lot of times in some of these corporate all-on-4 implant centers, they are not raising this kind of flap. They're kind of, and to me, that's doing blind surgery, because if you can't see, then you're kind of going in blind. All right, so here I'm using what's called a rongeur, and then I'm just kind of leveling off the bone, taking off any sharp points. I'm not doing a 10 millimeter alveoloplasty, which is, Clear Choice will cut down 10 millimeters of bone in order to create space for a plastic prosthesis, because they need that amount of space to give strength to the plastic. So, and then here I'm preparing the osteotomies, or the holes for the implants. And notice how slowly I'm drilling at first. I'm going through what's called the cortical bone, is the more dense bone. And then you can kind of see that drill fall into place. That bone's a little softer. So right now I'm in my mind, I'm thinking and I'm telling myself, okay, so I'm learning so much in this stage, because I am literally learning about the density of this patient's bone. Right here's a technique that I use. So my glove's in the way, but you can see I've put this osteotome right in the middle, but that's the incisive canal, and that canal innervates, or it has blood supply. Well, it's nerves to 8 and 9, to the central incisors. Those teeth are now gone. So there's no point or no need for the incisive canal. And also a lot of times it gets in the way of putting implants in the 8 and 9 areas. And so I will remove the nerve and graft that site. And so, and here you can see I'm going a lot slower than the video shows in these placement of these implants. It's just the video is sped up. It's a very delicate technique, very delicate procedure. So I'm not going this fast. It's just the video is sped up. But I'm placing each implant. I've prepared each hole or osteotomy very, very carefully. and I'm placing them what we call subcrestal. So I'm about 3 millimeters below the crest of the bone, so that, and I leveled off the ridge, and now I'm doing a sinus lift in that area as well. So you can kind of see we're going through this a little bit quickly, but we're placing all of the implants. I have plenty of torque. So when I use that gold torque wrench, I know exactly how much torque I have on all these implants. I've got over 70 Newton centimeters of torque. So I know that these implants are going to last her the rest of her life if she maintains them. And here I'm just placing graft material in order to kind of fill in any voids. Sometimes the bone will fracture, the buccal plate will fracture. And so I'm just laying down graft material, which is a mixture of autogenous bone. So I've saved the bone when I harvested from her extraction sites. I saved that bone, mixed it with donor bone, a mixture of puros, cancellous, and cortical, and then also bioos, small and large particle. And then here I'm laying down a membrane to kind of separate the gum tissue from the bone, and I've hydrated it with a doxycycline. So there's antibiotics in the irrigation or the hydration that I'm using. And these are all just steps to ensure that this heals properly. As I'm looking at her case, there's sufficient blood supply, the tissue looks good, extractions were done properly, implants have a lot of torque in each one of them. The osteotomies were under-prepared, so I will under-prepare the hole, stop at like a 2.3 millimeter diameter, and I'm placing a 4.3 or a 5.0 implant diameter. So I have plenty of space that implant can drive itself into the hole. And then here I'm just closing it up. This is a continuous suture, so I'm going to continue. It's not like interrupted, meaning one stitch at a time. I suture everything and get it nice and clean. And so this is basically laying the foundation for phase 1, which is the surgical phase, implant surgery, extraction, case planning, extractions, implant placement, and then grafting and membranes and closure. And so it kind of gives you an idea that it is a delicate procedure, but it's also one that is got to be planned right. But this is going to last her the rest of her life. She'll be very happy with the end result. All right, so that, and I just did the top. I could show the bottom as well, but it's essentially the same thing. So let me go back and let's see here. I don't know why I'm having such a hard time with this. Here we go. All right. So, and if you have any questions, of course, ask in the comments below. Here, this is the final X-ray. The reason I had to angle this implant here is because there's literally no bone on the patient's right-hand side. And so I did angle this implant, which I don't like to do that, but given the situation where actually I did do what's called a nerve lateralization. So I lateralized her nerve because it was actually a more anterior, more forward. So I moved the mental foramen and pulled the infraalveolar nerve back so I could get a little bit more space. So we did what's called a nerve lateralization. These are all calls I make as I'm in surgery. It's like, again, like I say, it's like flying an airplane. I have to kind of make adjustments as I'm going along so that I can give the patient the best optimal surgical, prosthetic, foundational outcome. Okay, so let's take a look at this patient here. So here's a patient, and this is a CAT scan, and it's a cross-sectional view. You've probably seen this case on YouTube, but I wanted to talk about it in the live stream because it's one of those cases where a patient has been to multiple offices, and I get why a lot of guys would say, I don't want to touch this. It's just too complicated. And oftentimes it is very complicated, but if you have patience and you know how to approach it, it is a wonderful case to demonstrate. And so let me just show you. So this is her nose right here. This is her lower jaw. I hope you can see my mouse. And then she has some implants down here. So lower jaw, this is the upper jaw. And you'll notice this is the available bone on the upper jaw. I don't even think there's 2 millimeters of bone. It's very, very little bone that she has left there. And let's go through and look at her case. Here's a picture in the mouth. So right up here in the front of the jaw, there's absolutely no bone left. And she was really tired of her denture, was at her wit's end, was kind of like, I just can't do this anymore. But she needed it for aesthetics, of course. She needed it just so that she felt somewhat normal, but was desperate to have implants. Her husband has implants. I actually ended up doing his case as well, but she just was like, I'll do whatever it takes to have this procedure done. And so as we had met multiple times, it wasn't like kind of a come in for your first consultation and, oh yeah, this is the right thing for you. This was took a lot of planning, a lot of, just extra time with the patient, making sure they understand, because she had to go, for example, she had to go without a denture because I didn't want anything on top of this graft for about 8 months. So she had to be willing to do that and sacrifice that. And she was, and it ended up turning out to be a wonderful case. So this is the preoperative x-ray. Again, you can see there's just absolutely no bone in the front of her jaw. These are her maxillary sinuses, the posterior maxillary sinuses. So again, not a lot of bone there either. And so let's see, I think we have a video, right?
Doctor, question for you.
Yes.
When you say that she's been to the doctors and they've, a lot of them have turned her down, why is it that some doctors can place bone like yourself and others can't? You know what I mean?
Yeah, honestly, I don't know, because I really have no idea what and I'm not saying I'm the only guy that can do this. I know plenty of guys that would be able to manage this case. Each von Urban, he's very good growing bone in the back of the lower jaw. There's certain guys out there that are super good at growing bone, Sasha Jovanovic. But it's a matter of being able to evaluate the case, understand what my limitations are, and also knowing the patient and understanding the outcome that you can expect. So, I mean, I don't really know, because I don't know what other practitioners do in their practice. But it's a problem, because we do see this quite often. We'll see patients they've come in from other practices and they've been told they're not a candidate. And I'm not saying that everybody is a candidate by any means, because I'm sure there are cases that I could say that there's just not, I feel like I am one of the top when it comes to bone regeneration. But when the patient has lost that bone, you have to know how to do it, and how to execute on that. And in her case, and in any case that I've done thus far, after 22 years, we've had a very, very high success rate with it. So, but to answer your question, I don't really know, because I don't know what other doctors do,
Yeah.
or their skill set. Implant surgery, like in a lot of surgical practices, is not their main focus. So they may do 20% of their practice might be implants, and then the rest is wisdom teeth or orthognathic surgery or trauma or other things. But dental implants are not the big focus within like a surgical type practice.
Okay.
And so I've dedicated my entire life to it. And so when a patient comes and they have these issues, plus in my training, we learn how to deal with resorbed maxillas, upper jaws that have no bone, and how to graft those areas and how to regenerate that bone. And it's, fortunately, it's not all of my patients because it is a lot of work. And it's very expensive. That's the other factor that keeps people from doing it. The bone graft itself, just the graft can be, 40 grand.
Okay.
Yeah.
Yeah, but there's times where it's
Well, yeah, like in her case, she's like, honestly, not that she said, I don't care what it costs, but basically she's like, I will do anything to get rid of this denture. And rightfully so, because she was truly, and she had gotten to the point where she had lost so much bone that even the denture wasn't working anymore. So she had to really make that decision. And I'm glad she did, because in the end, it turned out beautifully. And I'll show you now the video of this patient. And you've probably seen this on YouTube. It's a bit long, but we'll go through this video and look at her case, hear her experience, testimonial. But it's a remarkable case, because she went from, like I said, almost not even be able to wear a denture anymore because she had lost so much bone, to now having a fixed, solid, permanent set of implant prosthetics. So we'll go ahead and watch this video for just a second. So here I am, just kind of doing the surgery itself. So this is actually after I had done the graft. So we're going to see a titanium mesh. So this, I would have to bring up the other video of doing the graft itself. And so there's some fixation screws that are holding. It's like a screen almost, and it's a titanium screen or plate that's in her mouth that separates the bone from the gum tissue. And then the material I used to regenerate the bone was a mixture of autogenous bone, so her bone, and then I also used what's called bone morphogenetic protein. So those two, and we grafted her sinuses. So a lot of foundational preparation went into the development of her arch, because I had to regrow this bone, and we had to grow about 10 to 15 millimeters of bone in order to get implants in, because I need to place at least an 11.5 millimeter implant, and she had about 2 to 3 millimeters of bone. And so I had to grow 15 millimeters of bone in order to get an implant that was 11.5 millimeters in length. So right here, we're just removing the titanium mesh, and it's high-speed video camera. We're not moving this quickly and being this aggressive. It's just the fact that we don't have 2 hours to watch, because this surgery was probably 6 hours. And so we're going to go through kind of quickly just to kind of visualize. And you can see after I've gotten the mesh out, how that ridge it's fat, it's bleeding, we have so much beautifully, and it's not me. It has nothing to do with me. This is all me working with the body. And in the end, like I said on my last live view, God does his magic. I just ask the body to do things, and I rely on him, and this is the end result. So right here, we're just preparing the holes for the implants in a site that literally had no bone whatsoever, and I'm placing 8 implants. And here we go. We're just going in, putting those implants in place in a site that literally there was no bone there 9 months prior to this. So I like to kind of show this case because it is possible. And now that we have, and I'm getting 70 plus Newton centimeters of torque on every single one of these implants. These little tools that you see as I'm driving or rather than removing bone, I am expanding the ridge. And the tool that I had put in right before this implant was called an osteotome. And that I use so that I can expand that ridge. I'm not going to expand or remove bone to a 5 millimeter when I'm placing a 5 millimeter implant. I'm going to condense that bone with a smaller diameter osteotome so that I can put the implant in and have that bone engage the implant rather than. So right here, there's the purple one's a 3.5 millimeter diameter osteotome, and then I'll put in that looks like actually looks like a 5.0. So I went from a 3.5 diameter osteotome to a 5.0 millimeter diameter implant. So getting very nice. I can feel the feedback on my drill. It's giving me feedback on that implant, and I'm happy to actually push and hold back on the placement because I have such good bone density. So here we're just doing the other side, starting with the pilot drill, which is a 2.0. I started at 1.5 millimeter. I go to a 2.0 millimeter pilot drill. So that's why you're seeing me drill twice. So I'll start with the 1.5 millimeter, and then I go to a 2 millimeter, and then put my parallel pins in there so that I can. And again, implants going in, I feel that resistance. I feel the torque coming back on the drill. And then I'm putting healing caps in here. So I know that I've got good density on every single one of these holes or osteotomies because I'm able to. Normally I'd put what's called a cover screw. If I did not have a lot of torque on these implants, I'd put a cover screw, but because I do have such good torque, I'm putting a cap or a healing abutment on there. The reason is because sometimes the healing abutment protrudes through the gum tissue a little bit, and we don't want any force on them if I don't have good torque on those implants. But I have plenty of torque. I've got good bone that I'm working with. You can see in the hole or the osteotomy, like blood comes back out. I know that also tells me that the graft has good blood supply. And it's kind of spinning here, but there's just so many things that are giving me feedback and telling me, that the graft worked great, and I've got, blood coming back out of the hole that I'm putting the implant into. So, and you see how fat that ridge is right there. There was absolutely no bone there prior to this graft. So, and again, got great torque on the implant. It's driving in the hole really nicely. And it also speaks to the implant itself. So this is a Nobel Active, and it does what's called osteocompression. So that bone drives, because the threads are pretty aggressive, it drives into the hole really nicely, and it engages the bone. So certain implants, like I wouldn't consider using a different brand of implant in this case, because I really need to fixate as much of the bone as I possibly can. And that's where the Noble BioCare Active or the Thai Ultra comes into place. It really does make sure that I get good, solid, rigid fixation on each implant. So here we go with the last one, placing it into place. And again, in this area, I had zero bone whatsoever. And this bone will continue to mature as time goes on, and as the patient, this was about 9 months after the initial Thai mesh onlay graft, or when we put the titanium mesh in, we waited 9 months. And the graft will continue to mature and get harder over time. So there you go. I mean, we've got 8 implants in a maxilla or upper jaw. Again, I'm putting a membrane down, hydrating it with doxycycline. It's an antibiotic. Putting the membrane over all of the implants, and just to, again, separate gum tissue from bone tissue, making sure that no bone tissue kind of invaginates or go inside the osteotomies and just separates the two. And just closing it up and using a continuous vicryl furrow suture. And that, makes it look like it's very easy and fast. That's on high speed. But, again, this surgery probably took us about 5 hours to do. But in the end, this was the right move for her. And she'll tell you, she will say that she's so happy she did it. Now, this is putting a denture in over. All right. So that was the implant surgery. And I'm not sure if we have her testimonial on here.
Dr. Willardsen, so in a case like this, since you showed the pictures and there was no bone at all, she came in for the extractions first. You placed the bone and she had to wait 9 months.
She actually didn't have extraction. She was missing all of her teeth.
Oh, she was just missing all her teeth.
Yeah. The first video we showed was extractions.
Okay.
But I didn't have to do the extensive type of grafting on that case like I did on this case, where we did a titanium mesh onlay graft in order to build the bone. The first surgery I showed, she had pretty good bone. She had decent bone to work with. In fact, I was removing bone.
Okay. But for something like this, it took about 9 months for that to heal. So this was probably this whole procedure with, in a case like this, there's no bone, it's probably like a year and a half.
At least. Yeah, her case took about a year and a half to finish. Yeah.
So this whole 24 hours, taking 24 hours, especially when there's no bone, it's
not going to happen.
It's not possible.
Definitely not. Yeah. I mean, honestly, even the first surgery we looked at, she actually went to one of those places and they offered her, teeth in 24 hours. And thank goodness she didn't do that, because it required a lot more than just, and again, the foundation is important, but also planning out the case and knowing where you're headed with the case, proper number of implants. It just wouldn't be wise to go and have just 4 implants supporting 14 teeth. And then all of the kind of additional surgery, because they do a lot of times what they call flapless surgery. So they don't raise a flap, so they don't really know what's going on underneath. They just stick the 4 implants in with the surgical guide. I don't know, and again, I don't really know exactly what they do. So, but anyways, so I don't know if we have Mia's testimonial on here. And again, if you guys have questions regarding these cases or surgeries, feel free to ask in the comments. And, that's why we're here. We want to make sure that anybody who's needing these procedures has the information, they're armed with the information, so that, when you go for a consultation, you can have as much information as you possibly can and get the best long-term results and outcome possible. And so, let's see. Anyways, I think that'll probably do it for today. Again, hit that like button, subscribe. We have lots of information that we can share with you. And, we're happy to do that and very passionate about what we do. And so I'm Dr. Willardsen, and thank you for watching the Trust Implants live view. And we'll see you next week on Wednesday at 9 a.m.
Thank you, everyone.